Okay, great. So thank you so much everyone for joining in today, this Friday evening for our cardio colloquium. Today we are going to discuss a very important topic of the optimal selection of RAS blockers, especially in the post-MI patients. But before we begin, it's a pleasure to invite Dr. Eliginan, which is, of course, he doesn't require any introduction from our end. He's the Director of Endovascular and Peripheral Vascular Division at the MMM Hospital, Chennai. We welcome you here, sir, today for moderating the session. Apart from that, we have our esteemed faculty here with us, the legendary Dr. V.T. Shah. Sir works at the Preet Candy Hospital, Mumbai, and Dr. Saket Bharadwaj as well, who's again the Principal Director and HOD of the Department of Cardiology, Venkateshwar Hospital, New Delhi. With this, sir, I welcome all the experts here today, and we look forward to an insightful discussion on the optimal selection of RAS blockers, especially in the post-MI patients. Over to you, sir.
Thank you.
I'm sharing from my end. Yes.
Thank you, Dr. Ronak, for the wonderful introduction and setting the momentum to go. I'll start sharing my screen. Is my screen visible now?
Yes, sir.
Okay, thank you.
Wonderful. Please go ahead.
At the outset, I would like to thank MCure for giving me the opportunity to moderate this session, along with two luminaries, Dr. V.T. Shah and Dr. Saket. And the topic for today will be optimal selection of renin-angiotensin-aldosterone synthesis inhibitors in post-MI patients. So basically, the RAS inhibitors that are available for a patient post-MI are ARBs, ARNI, AC inhibitors, and then we'll look into what the current guidelines suggest. Now, looking into ARBs, the two ARBs, among the 7 agents, the 2 ARBs which have evidence to be used post-MI are optimal trial and valiant trial. In optimal, which was done in 2002, it randomized 5,477 patients. Losartan was the molecule used. It was given at the dose of 50 mg once daily versus captopril 50 mg TID. And what we found was a non-significant difference in the total mortality in favor of captopril. Then the same next year in 2003, Valiant study came, which involved more than double the population, 14,703 patients. And valsartan was compared with captopril. And what it showed was that valsartan is as effective as captopril in patients who are at high risk for CV events after MI. And combining valsartan with captopril increased the rate of adverse events without improving survival. So basically, losartan did not win over captopril, but valsartan was the only ARB to show that in a post-MI setup, if you want to give an ARB, you can give valsartan. But of course, AC inhibitor was better. Now, this is the optimal trial where you could see there was a non-significant difference in total mortality in favor of captopril. And thus, ACE inhibitors should remain the first choice treatment in patients after a complicated acute myocardial infarction. Losartan cannot be generally recommended in this population. So this was a negative trial for ARB versus ACI. Then the Valiant trial, where valsartan molecule was used. Here, mortality from any cause and cause-specific mortality were similar in the 3 treatment groups. The third treatment group was combination of valsartan with captopril. And you can see that the rate of the secondary endpoints of death from cardiovascular causes, recurrent myocardial infarction, or hospitalization for heart failure was similar in the 3 groups. So here, valsartan seemed to be equivalent to an ACE inhibitor. So that are the evidences we have with the ARBs. Now we'll go to ARNI. ARNI is supposed to be the molecule of choice for heart failure patient. We know that compared to all other 4 molecules of foundational therapy, namely beta blocker, MRA receptor antagonist, SGLT2 inhibitor, ARNI is the most powerful and maybe you can say number one molecule which should be used in heart failure. But however, in post MI setup, did it stand to its stature? So this is the Paradise MI trial. Basically, angiotensin receptor neprilysin inhibitor following acute myocardial infarction. In this trial, patients who had an AMI within half a day to 7 days with EF of less than 40% and had pulmonary congestion, plus any risk enhancer like age more than 70, EGFR less than 60, diabetics, prior MI, atrial fibrillation, EF less than 30%, CLIP class more than 3, and STEMI without reperfusion. All this, any one of this risk enhancer, if there, it was there, it was good for the selection. Major exclusion was prior heart failure, clinical instability, EGFR less than 30. They are randomized into two arms. One was sacubitril valsartan in the dose of 200 mg BID and the ramipril target dose of 5 mg BID. Number was 2830 in both. And the event driven should be 711 primary endpoints, and the follow up was 23 months. And what did we see? The cardiovascular death, first heart failure hospitalization or outpatient heart failure was seen in 373 patients with ramipril arm and 338 in the sacubitril valsartan arm. You can see the p-value 0.17, which was not significant. If you look at the CEC adjudicated primary outcome, the events and the event rates per 100 patient years, in the sacubitril valsartan arm, the primary outcome was 11.9%. In ramipril, it was 13.2%. And if you look at CV death, heart failure, hospitalization, outpatient heart failure, none of them were statistically significant for sacubitril valsartan. If you look at the adverse events, angioedema was seen in 0.5% in the ARNI arm and 0.6% in the ramipril arm, almost the same. Hypotension, however, you see was more in the ARNI arm and lesser in the ramipril arm. And cough was seen more in the ramipril arm and less in the sacubitril valsartan. Others were all equally poised. So in summary of this Paradise MI trial, sacubitril valsartan did not result in a significantly lower rate of cardiovascular death, heart failure hospitalization, or outpatient heart failure requiring treatment. Pre-specified observations of reductions in both the investigator reports of the primary composite as well as in the total adjudicated events support incremental clinical benefits of sacubitril valsartan. The safety and tolerability of sacubitril valsartan in this AMI population was comparable to that of ACI. So if you look at the comments after this negative Paradise MI trial for ARNI in acute MI, in the Medscape, they said that Paradise MI sacubitril valsartan can't beat ramipril in patients with acute MI. And in Medscape, it also said that Paradise MI makes me question the benefits of sacubitril valsartan. And in TCTMD, they said that Paradise MI did not surpass ACE inhibitor after acute MI. And ACC commented that Paradise MI sacubitril valsartan did not outperform AC inhibitor after MI. So these are all the negative comments given for the role of ARNI in MI. So as of now, we do not have strong evidence to support role of ARNI immediately after MI with LV dysfunction. Now coming to ACI post-MI trials. This ACI has the strongest evidence post-MI. You have so many trials. You have long-term trials like SAVE, AIR, TRACE, and you have short-term trials like Consensus 2, GC3, ISIS3. Most of the trials were done long-term back, and hence the parameters with how you educated whether the benefit was there differed. Now, for example, the SAVE, which was done in 1992, here the design was a randomized double-blind placebo-controlled multi-center study. Captopril ACE inhibitor was compared with placebo. Here, any patient with MI with the EF of less than 40% was randomized between 3 to 16 days post-MI. 2,231 patients were taken. And here, MUGA was done at baseline and 36 months to see the LV size and remodeling. So captopril maximum 50 mg TDS was compared with placebo, and the captogrel group showed there was a 19% reduction in mortality, 25% reduction in recurrent MI. The cavity dilatation was reduced as seen with the MUGA studies, and these benefits occurred equally in patients who received lysis plus beta blockers and in those who did not. So in addition to giving thrombolysis beta blocker, if you get an ACE inhibitor over and above the other two drugs, you get these benefits. The trace in 1995 with trandalopril showed this also was a randomized double-blind placebo-controlled multicenter study. In these patients with AMI with wall motion index of less than 1.2 were randomized between 3 to 7 days and were given trandalopril 1 mg per day, maximum of 4 mg versus placebo, and followed up for 24 to 50 months. And we could see 25% reduction in mortality, 15% reduction in recurrent MI, and 20% reduction in sudden cardiac death. The other evidences for ACI in post-MI are, you have the ISIS-4 in 1995, where 58,000 patients were studied. Captopril was effective in reducing 5-week mortality, and the survival advantage appeared to be maintained in the longer term. Then you have the GC3 in 1994, which involved 18,895 patients. Here the ACE inhibitor was lisinopril, which was started within 24 hours after MI, and it showed to be effective in reducing the mortality and severe ventricular dysfunction. Then you have the CCS1, which involved 14,962 patients. And here you could see antival infarction of captopril treated group was found to have lower mortality, 8.6 versus 10.2%. So these were all the other studies with ACE inhibitor showing benefit. Then you have this AIR study, which was done in 1993, acute infarction ramipril efficacy study. Here, this also was a randomized double-blind placebo-controlled multicenter study, and it was done in acute MI with transient or persistent heart failure, randomized between 3 to 10 days post-MI. Oral ramipril 5 mg BD dose was given and compared with placebo. It was followed up for 15 months, and they could show a 27% relative risk reduction in the ACE group compared to the placebo group. Then the AIR extension study in 1997. Here, this also was a randomized double-blind placebo-controlled multicenter study. 603 patients who participated in the AIR study were followed up for 42 months to 59 months. The beneficial effects of ramipil started early after MI with heart failure was sustained over to 3 to 4 years despite discontinuation of medication at 1 year. So this showed the legacy effect of ACE inhibitors in a post-MI patient. You give them the ACE inhibitor drug for 1 year, and then after that, even if you discontinue and follow them up, you can still see the benefits over the years to come. So that is the legacy effect of ACE inhibitors post-MI heart failure. Then this is the AIR survival. Here, to assess the long term, that is 29.6 years after randomization, the magnitude of impact on length of survival observed after treatment with ramipril, target dose 5 mg twice daily, when compared with placebo. So again, the same 603 patients, inclusion criteria was the AIR inclusion, and they were followed up for 30 years. The primary outcome was life expectancy or all-cause mortality. The median survival was 8.3 years versus 9.6 years in the ramipril group. So extension of life of 14.5 months. Survival curves across at 14 years from the time of randomization, and life expectancy was greater at about 15 years. So the life expectancy was improved with ramipril across all the comorbidity groups. So this shows that not only for short-term outcomes, you have good effects with ramipril in a post-MI patient. Even after 30 years, you still see the benefits of ACE inhibition in a post-MI patient. So these were all the parameters where the life expectancy difference was attributed to diabetes, previous MI, history of heart failure, hypertension, angina, more than 65 or less than 65, all patients benefited from ACE inhibitor. So the results, substantial survival gains with Ramipral treatment for 15 years beyond the blinded treatment allocation. And overall, for every day a patient received Ramipral, on average, his or her life was extended by a further day. So relative risk of survival for patients with diabetes was increased by 54%. Patients with diabetes, previous AMI, previous heart failure, hypertension, and angina each benefited on average from ACE inhibition. And treatment with Ramipral for about 1 year, when started early post AMI in patients with heart failure, results in a survival benefit which is sustained over many years and offers on an average an extension of life of additional 1 year. So the concluding remark would be treatment with Ramipral for about 1 year, when started early post-MI in patients with heart failure, resulted in a survival benefit which is sustained over many years and offers on an average an extension of life of an additional 1 year. So now what do the current guidelines say? If you look at post-MI, this is the state-of-the-art review article by Bahit et al. And in JSCC heart file, you can see that after an index MI, immediate perfusion for ST segment elevation is the indication. And then early initiation of ACI within the first 24 hours will give long-term benefit for a patient with ACS. And previously, we were giving even IV beta blockers immediately after MI. Now it has been discouraged. And what they say now is avoid beta blockers for the first 24 hours for ongoing heart failure. And then early introduction of aldosterone antagonist, MRA receptor, within 7 days also benefits immediately after an MI. And then re-evaluate eligibility for beta blocker therapy here, and then start a beta blocker at this point. And it is also critical to titrate the dose of the ACE inhibitor. So just don't start and leave it there. Try to up titrate and go to the maximum tolerable dose of the ACE inhibitor for gaining maximum benefits. So thus early ACI therapy offers maximum benefits in a patient post-MI. And the JSCC acknowledges the AIR study, and this is what it published in Lancet, that ACI should be administered within the first 24 hours for heart failure of EF of less than 40%, heart failure patients of EF less than treatment early initiation is important. So it's not only important to start, it is also important to start early as day one. And if you look at the 2020 ESC guidelines for the management of acute coronary syndromes in patients presenting with persistent ST segment elevation, ACE inhibitors or ARB in case of intolerance to ACE inhibitors. So AC is the first choice. ARB is only if you are intolerant to ACI, are recommended in patients with heart failure with reduced ejection fraction, diabetes or CKD unless contraindicated. So it's a class 1A indication. Similarly, beta blockers and MRA also have a class 1A indication. But ACE inhibitors are the first drug to be started immediately post-MI. The recommendations for other RAS inhibitors are in high-risk patients with the ACS, patients having hypertension, diabetes, or STEMI with anterior location, or ACI or an ARB is indicated, class 1A indication. And patients with similar conditions, the mineralocorticoid receptor, MRA, has a class 1B indication. And in patients with ACS who are not considered high risk, and oral ACI ARB is reasonable to reduce MACE, but it's only a 2A indication. So I think with this brief introduction, now we'll go into panel discussion. Luminaries like Dr. V.T. Shah and Dr. Saket will give their opinions to the questions I'll put across to them. And then the panelists, other audiences can also interact. So my first question will be to Dr. V.T. Shah, sir. Sir, in the post-MI patient, post-revascularization, at what systolic BP do you initiate ACI therapy? What is the starting dose you will recommend, and how do you uptitrate the dose?
Yeah. In fact, Dr. Ezilan, I was supposed to ask you this question. But anyway, I'll answer as to what my point of asking was something different. But first of all, let me congratulate you for that excellent review of RAS inhibitors in post-MI situation. So first of all,
I think there is a
They're muted, sir.
Dr. Vitisha.
Sir, we are not able to hear you. You are muted. Or should we go to Dr. Saket Bhardwaj's question and then come back by the time Dr. Vitisha will be back?
Sure, sir.
Okay. Dr. Saket Bhardwaj, sir, this question is for you. Will you switch the patient to an ACE inhibitor if the patient at the time of was receiving ARB for hypertension?
It's a difficult question, but I feel like both should be more or less similar. Class effect should be there. That's what I feel. Similar is RAS inhibitors. I may or may not. ACE inhibitors ideally is the first choice, but I may not shift. That's like I'm not very sure at this point of time. If the patient is already on angiotensin receptor blockers, I may not change it.
Yeah. Sir, I mean, like, if you look at the trial evidence, only
trial evidence is with ACE inhibitors.
No, not for ACE inhibitor. I mean, like only the two ARBs, losartan and valsartan, have some evidence.
Yeah, patient should be receiving. Yeah, that's there. Patient should be receiving. This question is that the patient is receiving losartan or valsartan, I would change. But if definitely telmisartan is there, I would shift.
Okay. So if other than these two ARBs, if it is some other ARB, you will change it. But if it is either losartan or valsartan, you would continue the same.
Yeah, continue the same. Yeah.
Right. Thank you.
Can you hear me?
Yes, sir. Yes, sir.
Yeah. So do you want to go with Dr. Saket? You can go ahead.
No. We are done, sir. Now we'll come back to your question, sir.
Correct. So as I was saying that we still do have a role of RAS inhibition in this post-PAMI era, one. Secondly, the effect or the benefit may not be as much as was shown in the pre-PAMI era or pre-revascularized, because even today in India we have so many patients who do not undergo a PAMI immediately, and then maybe they take time or stage or something like that. But here the role of RAS inhibition is important. Now, at what systolic blood pressure do you initiate ACE therapy? So basically one has to look first of all that the patient is not on vasopressors, because many of our cardiogenic shock patients or many of our anterior MI are borderline and are sometimes on vasopressors for the next 2-3 days, and then once they stabilize we get them out of vasopressors. So the systolic blood pressure should be around 100 at least, and without vasopressors, that should be there. And there should be otherwise no contraindication to give any such remodeling therapy. What is the starting dose? See, when we started practice and when ACE inhibitors, actually you started your lecture with ARB, but ACE inhibitors were the first to come in the market for RAS inhibition in acute MI, and that started with the story of captopril. Now, captopril had an advantage and disadvantage. The advantage was that it was 50 milligram TID, you can give it half TID and so on. and if there was hypotension, it would be transient for 4-6 hours or something like that. And in Ramipril, the action is a bit longer. But here, what we have started doing, because Ramipril has got so much of good data, we started giving 1.25. So 1.25, give the first dose and see whether there is hypotension. If not, make it 1.25 BID and then up titrate depending upon the blood pressure response and of course hyperkalemia and EGFR. So during this therapy, we have to see that the patient is relatively well hydrated. Otherwise, if he is on aggressive diuresis and dehydrated, the hypotension would be much more, what we used to call as first dose hypotension with ACE inhibitors. And how do you uptitrate? As I said, depending upon the response of the patient, you go from 1.25 BID to 2.5 and ultimately 5 milligram BID. This is our goal. Now, the question which I was going to ask is that in the AIR study, where 3 to 10 days or 3 to 7 days was the window period in which the drug was started, what was their regimen and what was the average dose? They did say that you try to go the maximum, but what was their average dose at which they got stuck? Especially in anti-revolve MI, where the systolic blood pressure generated is not more than 100, 110 for at least for the first 4 to 6 weeks. So can you give us some idea from
Yeah,
the
in
study?
the AD study, they gave at a dose of 5 mg BD. So 10 mg was the maximum dose. If you look at the studies with the Ramipril, the post-MI studies, the average dose has been 10 mg per day, the maximum tolerated or maximum.
Yeah, maximum was 10, but
10.
I do not know whether anywhere have they mentioned that in some cases they have started with 1.25 BID or 2.5 BID or something like that, or every time it is 5 milligram
No,
BID.
it was, they have not mentioned that it was uptitrated. They have started at 5 mg BD in the
Yeah,
trial.
yeah,
Uh,
yeah.
But I mean, and practically, we usually start at 1.25, go up to 2.5, then
Yeah.
increase to 5.
Correct, especially when the blood pressures are on the lower
Low,
side
lower
and
side. Yeah.
the patient has just come out of cardiogenic shock of inotropes. There we are a bit more careful. If the patient is, let's say, posterior inferior wall MI or a lateral MI, where the hypotension incidence is quite less, then in that case, if the blood pressures are good, one can start with the dose of 2.5 or 5 also BID. But overall, we still use Ramipril as our first choice, even over and above ARBs. This is our first choice. Even over ARBs, there is a specific reason. First of all, of course, ACE inhibitors have good data. They have extra bradykinin benefit also. That is also there. But the other thing which is there is the dosage of the drug and the hypotension that will cause. You see the studies which were shown with ARB for losartan 50 milligram OD. That was the dose in that study, and valsartan. Now these drugs at this dosage do cause hypotension. Basically, that's the dose you give for hypertension. So when a patient is off inotropes recently and with a pressure of 100 around, to start such a high dose would be difficult, landing the patient in hypotension and maybe acute renal shutdown or worsening of EGFR and hyperkalemia. So basically, and the other thing is that the cough of the ACE inhibitors is not that will come in 2 or 3 days or something like that. It would come at least after minimum after 7-15 days, if not months together. So why not take the benefit early of the drug, and then when things stabilize and if he has cough, of course, the dilemma or the challenge always post MI patient when somebody starts getting cough is whether he is gone in failure or not. And now, of course, with the help of imaging and pro BNP, one can decide whether the patient is in failure or not, as against what it used to be in the pre-pro-BNP era. Only X-ray chest was available and clinical findings. So I think overall still we stick to ACE inhibitors plus the flexibility of giving 1.25 OD, BD and so on. And therefore, and now with this RX extension study, we will be much more confident to give ramipril in these patients and give the benefit, and easier to convince the patient that you are going to get long-term benefit of this. And mind well, even in that Paradise MI trial which you said, the dosage of ARNI was 200 milligram BID versus 10 milligram of ramipril. I mean, 10 milligram of ramipril hypotension is no comparison to 200 BID of the ARNI. And how many patients of us are going to tolerate 200 milligram BID to be equivalent benefit to ramipril, not superiority, but equivalent benefit. So, in practice, if you see, our usage of ramipril would be much more than an ARNI, especially now since it has not shown any great advantage of that.
Yeah,
So
well,
these are my overall comments on this
yeah.
question. And
Yeah, I agree with this. Why would one want to spend more money on ARNI in post-MI patient when there is no evidence for that? So one practical question, in the trials, they have used 5 mg BD. Is BD dose really required? I mean, we give only OD dosage. We try to give 1.25, then make it 2.5 OD, then 5 OD, and many a times you don't reach at all 10 OD. So, do you think OD is enough, or BD should be given like in the trials to gain that benefit?
no, yeah. So excellent question. I mean, I would say that I would go with BID just to be on safer side for hypotension. One, if I am treating a patient for hypertension with ramipril, then I would prefer to give him 10 milligram, especially at night time, which was used in the trial, the HOPE trial. But if I am using as the AIR protocol, then I would better start with BID dosage and try to be much more safe than rather giving immediately some 5 milligram or 10 milligram OD. And the problem is that initially in this period, especially post-MI and anterior MI and all that, there are also chances of postural hypotension when we mobilize these patients. So, I mean, just to be on safer side, not that if your ICU setup and if your assistants and everybody is very careful enough and they can watch everything and observe, then it is fine. But otherwise, I mean, when we are practicing in non-teaching hospitals and private hospitals, which are not so big in number with infrastructure, not comparing to what you people have in uh, uh, five-star hospitals.
Dr. Saket, sir, would you give BD dosage of ramipril in post-MI heart failure, or you give?
Yeah, Dr. Shah has very, I think, elaborately highlighted the point that BD we give because we want to avoid hypotension. So if you give the 5 BD, if you give 10 at start and BP falls, so you cannot sort of control it. So 5 you give and then 5 you again give after. That is the basic giving BD doses. Or even people say that for ARNI also, it's not in this case, you can give ARNI single dose also. The people who has conducted the trial, they were worried that patient may not get hypotension. So they have made it BD. Otherwise, ARNI can be given in a single dose also. That's we learned from the person who had come to, I think a few weeks back. He came to India and we were discussing something. He told that this was the reason for giving BD. Otherwise, if in one of our patients, there are issues, we can give OD also. We give similar. So that is the reason they want to avoid hypertension. No other, I think there is no other, any other reason for this.
Thank you, sir. Dr. Vitisha, this is a second question for you. how early do you think an ARNI can be initiated in a post-MI patient? Now, post-MI, since there is no evidence for ARNI, we give ACE inhibitors. When will you think of switching from ACI to ARNI in a patient post-MI heart failure?
Well, if you go by the trials, not less than 3 months, I would say. If you go by the trials, okay, the trials of ARNI in heart failure, if you see the exclusion criteria, even in the paradigm trial, the history of MI immediately, I think it was 3 months, if not 6 months, but that was the exclusion criteria. So I would wait rather for the patient to get stabilized at least for 6 weeks or 8 weeks, and then would start an ARNI if there was a heart failure incidence which had occurred, or else there was enough evidence that even if the symptoms were not there, but the pro-BNPs were high and the ejection fraction still remains low, and so on. Yes, in practice, we do not wait for frank heart failures to start ARNIs after, say, 8 weeks or 12 weeks. Even in stage B of heart failure, where structural damage is there, the EF is low, and you have given ramipril, which was well tolerated also, I would still switch over to ARNI in these patients with whatever dosage they tolerate, for the reason that possibly the benefits of ARNI in such a patient would be much more than giving ACE inhibitors. This was my thinking till date, till this extension study came out. Now, then my problem is that ARNI doesn't have such long-term data to show that if you start the ARNI replacing the ramipril, which was well tolerated and at least at 10 milligram, then you will get some extra benefit. I don't have. So now I would really think in my practice whether to switch over or maintain as long as the patient doesn't go in heart failure or doesn't have any features of heart failure. So if this if you have the medical team there, they can try and find out that early that the usage of ARNI in pre-discharge patients, the trial, transform trial, or what was that known as, something from T. So that trial, how early was it? After 4 or 5 days, and how many patients of that trial were post-MI? It was heart failure, but how many of them were post-MI, I am not sure. So I would go by the dictum that I would wait for 6, 8 weeks or 12 weeks. And if there is a strong indication to start to replace ramipril and go for ARNI, then I would do. But with this air extension study, I would now, if the patient tolerates well and everything is fine, I would continue ramipril. What others have to say, let me know.
Thank you, sir. So, if at all you would start after 3 to 6 months ARB if required, but after our extension study, you feel that even ACE can be continued. Dr. Saket Bhadwaj, your opinion, sir, for regarding this question?
My opinion is once patient is settled, maybe a few weeks, then I would like to switch him over to RAS first, because you cannot directly go to ARNI, and then give him the benefit of ARNI. Because we know that particularly if LV dysfunction is there, then that is my thinking. I won't wait very long, because we have seen that it definitely benefits over ACE inhibitor. LV dysfunction, their study is definitely there. So I won't wait very long, but I would like the patient to stabilize first, because the likelihood of hypotension with the ARNI appears to be more. That's what we feel. So that is my protocol generally. After some time, shift into to maybe losartan. I usually take for the changing the switch over. I go to losartan and I switch over to ARNI.
Okay, right. So from my point of view, even I post MI, I would not start ARNI. I will definitely start ACE inhibitors. And switching from, I think definitely Paradigm HF showed that beyond ACI, if you give an ARNI, you had more protection. So I would also like to switch to ARNI. But maybe the time duration, I'm not sure, should be anywhere beyond 3 months or before 6 months. I think one would like to switch over to ARNI.
Yeah.
Okay. Thank you, sir. The next question to you, sir, Dr. Saket. Post revascularization, if you find LV systolic dysfunction, EF less than 40%, but without clinical heart failure in your patient, will you put the patient on ACI or ARNI?
I think I will put the patient on ARNI again for same reasons, because we definitely know that ARNI has the edge over ACE inhibitors. I don't think I will now go back to ACE inhibitors again. I'll keep the patient on ARNI.
Okay, post revascularization, I think he has already spent more than a month or three.
Yeah. After
With
ACE,
the MI.
initial ACE inhibitor, then ARNI.
So I think ARNI, you are justified in starting ARNI. Dr. V.T. Shah, sir, your opinion for this question?
No, in practice, as I said, I give ARNI even in stage B, that is without any history of heart failure. Okay, in practice. But my problem is that if I ask these foreigners or so-called ISPs who come here, they say that you see, where is the indication guideline to show that without history of heart failure you can give ARNI to a patient with reduced ejection fraction? Where is the indication? I mean, the guidelines, they don't mention that. So it becomes very difficult. We know that maybe ARNI would be better, as I said earlier also, that it appears that ARNI would be better in such stabilized patients over long term. But we don't have the evidence like that in stage B. All these studies of ARNI were either early post-discharge heart failure or with history of heart failure once. And if your patient didn't have any history of heart failure and he has just LV dysfunction, which many of our patients have post-MI revascularization, then in that case, the classical indication doesn't fit in as per guidelines. And now, moreover, with this air extension, I find it difficult whether in a stabilized patient on ACE inhibitor like ramipril, should I shift over to ARNI. I don't know. Now we should have a debate on this and try and find out or try and dissect all the studies of ARNI. And see, because the paradigm trial also, I was just going through the Google and said that there was history of myocardial infarction in 43% of patients, but they were to be stabilized like 6 months. That was it. And all of them should have history of heart failure. So that was paradigm trial. Now, the other studies we'll have to go and find out. Maybe the medical team should try and dissect all these ARNI trials. How early in an MI, post-MI situation was it given, like in the Paradise MI trial? And of course, that study did not show benefit over and above ramipril. And that is also for only short term. Forget about long term, like over a period of 10, 15 years or 13 years. So this is after this publication, I have to think really seriously whether I should shift in a patient or not.
Yeah, maybe Dr. Ronak will throw more light on this when we meet again for the next time.
Yes, of course, he has to do this. In fact, I thought he would dissect all this threadbare and then give us all this material so that we can go and convince the physicians, because they are the ones who treat these MIs. Once upon a time, they used to be people who were giving RAS inhibitors early, but now people have started even ARNIs, though although it's a good thing, but I think should not land up in complications.
Right.
Thank you, sir. This is for the expert panels. In the post-MI patient, post-revascularization, when do you like to start a beta blocker? Which will be your preferred beta blocker? At what dose you initiate and how do you up titrate? Will you advise an ACI plus beta blocker combination? So, Dr. Vitisha and Dr.
Yeah. So let us start. First of all, I was I was trying to see whether your slides did show any benefit of cardiac remodeling from ACE, ARB, or ARNI. I mean, because RAS inhibitors basically are drugs which benefit remodeling, cardiac remodeling, and the earlier we start, the earlier we get the benefit of remodeling and long-term improvement of ejection fraction. So that is what Dr. Ronak should give us some 1 or 2 slides on LV remodeling following RAS inhibition, which we used to uh, study when these trials were presented. Sorry. So now, when do you like to start a beta blocker? Of course, not in acute heart failure. Of course, or immediate post MI with hypotension, and in acute heart failure, and initially in the days of pre-ivabradine for control of heart rate, we always used to take this risk or chance those days. But now with ivabradine available, even in those low blood pressure 90, 100, we don't start beta blockers immediately and would prefer for the control of heart rate of 120, 140 or 110. We would like to give ivabradine and control the heart rate, plus at the same time treat the other problems and try to bring up the blood pressure and avoid heart failure or treatment of heart failure, and then start a beta blocker. And even when we start, uh, I mean, there are situations where we start with metoprolol tartrate at 12.5 milligram BID. I don't go to bisoprolol and all that, or neither I go for carvedilol. My drug of choice is short-acting beta blocker like metoprolol tartrate. Give at 12.5 BD, or so that even if hypotension occurs, you can hold it and there is a short life instead of giving the succinate long-acting one. So that is how, and then up titrate depending upon the requirement of the patient, as far as and how much the patient blood pressure and pulse allows us to do, and then gradually up titrate that. And would you advise an ACE plus beta blocker combination? Yes, I mean, as I said, that I would like to see that I give good ACE inhibition for the beginning. And if my pulse rate is fast and I have to control, I would better control it with ivabradine till a stage comes where, say, of course, there is this ramipril 5 milligram BD, and now I have scope to add something else, and that would be a beta blocker. So stop the ivabradine and start the beta blocker upgradation. Now, the benefit of beta blocker would be by sympathetic blockade, and that would be not in terms of remodeling also, but in terms of arrhythmias also. So the place where sometimes I would skip over or I would add a beta blocker early or before ACE inhibitor is when there are post MI arrhythmias. So that is the situation where I would prefer a beta blocker over an ACE inhibitor early, but if possible, try and add both. So depends upon the situation, but this is what my take is on this question.
Thank you, sir. Dr. Saket, sir.
Yeah, Dr. Shah is right. Ivermectin we use early phase when there is hypotension or something. We are really afraid whether it will further worsen the hypotension. But definitely beta blockers have an edge in arrhythmias over ivermectin. And in using beta blockers, I use bisoprolol because of all the beta blockers, bisoprolol has the lowest fall in BP. If you go into the pharmacology, it has the lowest fall in BP. So I start with 1.25 BD, that way 2.5 BD. That's my choice. Otherwise, as far as management, all are equal. That's what we know, whether metoprolol, bisoprolol, this thing. So my choice commonly, if patient is lower side BP, then definitely bisoprolol. Otherwise, any of them.
No,
That is the
I have no problem with your using bisoprolol except for two minor negative points. I would say that if at all your hypo occurs, it will last for 24 hours.
But I give
instead of
low dose,
yeah, low dose.
1.25.
Yeah,
Start
that
with
is
low
one.
dose.
And secondly, if you compare the evidence as far as metoprolol versus bisoprolol in post-MI situations, you will find more evidence of course,
Relatively
metoprolol rather than bisoprolol. Bisoprolol in acute MI situation, there is hardly any study on that.
Advantage with bisoprolol, what I feel is fall in BP is relatively less compared to
Yeah,
metoprolol. That is the
correct.
reason for using bisoprolol in the
Yeah,
acute patients.
sure. No problem. Nice. Good.
Yeah, regarding my opinion would be, when do you start a beta blocker? Of course, if patient is not having hypertension, then I would start even within 24 hours. Unless patient is in cardiogenic shock, pressures are low on inotropes, then maybe I'll wait even for a week to start a beta blocker. And which will be your preferred beta blocker? If the patient is having VPCs, patient is throwing VT, then definitely I would prefer metoprolol. But if there are no arrhythmias, then I also would prefer bisoprolol. Somehow I have got used and tuned to using bisoprolol, starting with 1.25, then going to 2.5, then 5 and 10. So the titration is very easy with the bisoprolol compared to other beta blockers. That is one thing. And as I said, so initiating will be a low dose of 1.25, and then I can go up. Previously, I mean, we were giving only ACE inhibitors first, and beta blockers initially was contraindicated. Then we started giving, but only after ACE inhibition. But when after CBIS2 showed that you can even start a beta blocker first, so I think now I don't have any hesitation even in starting both drugs together if the pressures are holding. So I would initiate any drug before, unless there are contraindications. Like patient is pulmonary edema, definitely I would not give a beta blocker. Patient is hypotensive, I would not prefer ACE inhibitor. Then will you advise an AC plus beta blocker combination? I would definitely feel that bisoprolol plus ramipril combination, if it is there, then maybe once the patient is stabilized, I would start it individually. 1.25 of bisoprolol and 1.25 of ramipril, and then once he is stabilized, then maybe I'll go with a fixed dose combination also.
Very good. So, Dr. Ronak should try and find out the studies of bisoprolol in acute MI or post-MI situation. Some studies, small studies, large studies, or whatever they are. Just for our knowledge, because we are practicing, it looks rational what you say. If the hypertension is less, why not prefer bisoprolol over metoprolol tartrate? But if he gets us some evidence, then that would be nice, especially if it is comparison with metoprolol tartrate in post-MI situations.
Right, sir. We'll definitely share.
Yeah. Some homework for you.
Yes, always something to learn when we interact.
Yes.
Next question is to Dr. VT Shah, sir. Do you consider NT-proBNP as a deciding marker for choosing ARNI or ramipril?
Oh, if I have to choose ARNI over ramipril, yes, NT-proBNP I would consider. And if the anti-pro-BNP is normal and just borderline, then I would still go ahead with Ramipril and continue that. So, because I mean, Ramipril is like a broad spectrum RAS inhibitor. It has shown improvement in various situations, I would say. So, I would prefer that. Now, ARNI, again, we have to try and find out in to initiate ARNI in a normal anti-pro-BNP, what is the evidence? I'm not sure. Yes, there are some studies of giving ARNI in resistant hypertension. The Japanese people have some study. But that is for hypertension, not in a post-MI situation. So I doubt if there is any evidence, then let us hear from other panelists or Dr. Ronak.
Yeah, I think if without a evidence such as anti-pro-BNP, it may be tough to switch over to ARNI. Then ACE inhibitor definitely sounds better. Because it has to be high if you really want to start ARNI.
And this question, I hope is it regarding post-MI or you are asking in general?
Post-MI, I think this is post-MI case.
No, the question doesn't mention, but just to clarify, hope because the title of our study, I mean, webinar is post-MI, so hopefully this is post-MI situation.
Yes, a post-MI itself.
Yeah. Okay. So just try and be specific on that. And that's okay. Yeah, fine. No, unless we extrapolate and off-label use of, as I said, using ARNI in stage B of heart failure, where there is structural damage, ejection fraction is low, but the anti-pro-BNP is just borderline or normal. What tolerate percentage 200 versus Ramipril 5, which was given in Paradise MI trial?
This is a critical question, sir. I mean, in your personal practice, in what percentage of post-MI heart failure patients you are able to give ARNI 200 BD or Ramipril 5 BD?
I would say less than 10% ARNI 200 BID in practice. Okay. Ramipril 500 milligram BID, of course, but let us say, what is percentage patients tolerate which was given in Paradise MI trial? Yeah, but Paradise MI trial, the starting dose of ARNI was 200 milligram BID. That would be very difficult in a post-MI situation unless he's an hypertensive with an acute MI and still has hypertension. That's another story. But otherwise, to start would be very difficult. To uptitrate and then come to 200 BID also would not be more than 10%. 5 milligram BID, of course, I think almost 75% might go and achieve within a span of 6 to 12 weeks. Or earlier than that also.
Dr. Saket, sir?
Yeah, I don't rather see that you can start 200 milligram. I don't know how come they have done it. What kind of patients are there? Or is the difference between Indian patients or maybe the Western patients? I have no idea, because 200 BD after MI, you can't take the risk. The patient will go into hypertension unless patient is some lateral MI or something. So, and very few patients in our practice rather reach 200 BD. We end up with 100 BD. That's the commonest thing. Maybe very few patients, they do have 200, but to reach a dose of 200 post-MI sounds very tough. And it's better I'll be better happy with the ACE inhibitor rather than starting 200 BD.
And the other thing to note is, it is a different situation in a trial platform, okay, or on the background of a trial to go to high dose and take the risk of hypo or hyperkalemia, because the patient is well monitored. You see, all the side effects and everything is monitored and treated. What happens in routine practice? If you get hypotension in a post-MI patient, suddenly relatives will be on your head saying, "Kya ho gaya, sahab? Blood pressure kyun low ho gaya?" Because everybody is worried about the extension of ICU stay. They want to get out as early as possible.
Or there are some exclusion criteria, like they cannot start it less than maybe 110, 120, like that. I don't know what was it in detail.
No, I'll tell you. Actually, this question, there were some Indian patients in this Paradise MI trial, and so we had this discussion. This Paradise MI was presented during COVID times, and we had a webinar on this on the platform of Classic Cardio Academy, which we used to have in those days. And we had a discussion on this, and one or two of those participants of this trial were there on the webinar. And they said that yes, 200 milligram BID we could go up to, but we had somebody looking after the patient, his blood pressure, potassium, and everything. So we were not bothered. We just went as per protocol. So it's a monitored situation, you see. And here, I mean, for us, it's very difficult to monitor the patient outside the hospital.
No, but they are starting inside the hospital or outside hospital?
No, this Paradise MI was inside the hospital.
Inside the hospital.
Yeah.
And the first go to give it 200 milligram to a patient, a post-MI, I don't know.
Yeah.
Plus, it looks very scary.
Scary, absolutely, absolutely. I mean,
Yeah.
not at least, of course, by the way, these were teaching hospitals, public teaching hospitals, okay? Not the private hospitals or corporate hospitals which we have. Anyway, so maybe someday if we get
So
a
they
patient.
start with 200 BD or they start with maybe 100 or 50 and
No,
then
there was a time duration given, if I am not mistaken, within 15 days or 3 weeks, they were supposed to reach 200. Something like that was there in the trial.
Right, sir. They were all up titrate to it to 200 mg
Yeah,
BID. Same for
correct.
Ramiptal 5 mg BID.
Correct. And there was some time duration, I believe. I don't
Right,
know.
sir. You rightly mentioned.
Yeah.
they were all up titrated. If suppose patient had low BP, then even then they will go to 200 BD. There must be some, I think, some it's difficult to say that. And people, there must be patients who may be having hypertension. So what?
Right,
They
sir.
left out those patients or what?
So hypotension was seen much higher in these patients because of ARNI, this high dose
Correct.
as well.
Yes. Hypertension in the trial was more common with ARNI.
Okay. So then why do we want to try that 200 BD?
Anyway, that is for the
It's just the protocol.
participants of the Paradise MI trial. At least now we are relieved that that trial has made us not to use this drug during the acute MI phase.
Correct.
So I think that was the last question.
Okay, good.
So if there are any questions the panelists would like to ask or
No, my
their
only,
opinion.
like we had a very good discussion, and your presentation also brought out many points. Because, we are from that era when we started Ramipril or ACE inhibitors during post-MI situation. I am sure Dr. Rezilan and Dr. Saket also would be houseman registrars during those days. At least I was there in the ICU, and we were all excited with captopril.
Yes.
Forget, Ramipril came later on. When captopril came in, because we had hardly any drug post-MI, and PAMI was not the norm that time. So, I mean, patients, when we used to give captopril, we were all excited and would monitor the patient and things like that. Anyway, so my idea is that Dr. Ronak now should get some more data comparing all this, and all the other evidences, whether are there or not there, directly, indirectly, subset analysis, or some small studies. If you get this data, actually, I always feel that Ramipril in India, after the aggressive marketing of HOPE study, which was done by Dr. Salim Yusuf, then somehow after Telmisartan took over, everything went underground, and there were hardly any people promoting Ramipril. Even today, if you see marketing of Ramipril, hardly few companies, and those are also not at the forefront. Except, this even this Sanofi people. We had a big meeting about couple of years back from Sanofi before they withdrew all this. And I used to tell them that you are marketing a product which is very good, proven, but where are your combinations? You are giving a combination of 5 milligram Ramipril with 5 milligram amlodipine when you say that the therapeutic dose is 10 milligram. You should have that combinations available. Then, of course, it's very easy to give these drugs. So, and secondly, the noise level is hardly anything. And so I don't know. I mean, after telmisartan, the noise level, but in situations like MI and all these conditions, in heart failure, I understand ARNI has taken over. But in post-MI situations, still today, I would say that Ramipril would be preferred. And even further down, the patients of EF of hardly 10% and who can hardly tolerate anything, Ramipril would still be a choice if the patient doesn't tolerate ARNI. So many people get giddiness with ARNI, postural hypotension with ARNI, and then I still prefer to give them this Ramipril. Even your combination of Ramipril plus metoprolol, which you have, what dosage do you have? You should give full dose so that the pill burden is less and everything is there. And now, as if you get evidence of bisoprolol in this post-MI situation, maybe you should have a combination with Ramipril. Or in hypertension also, I don't know. You may still prefer bisoprolol with Ramipril, high dosage, of course.
Actually, I think telmisartan has picked up because of hypertension. People
Yeah,
use
no, because of aggressive marketing, sir. You
in
tell me,
hypertensive patients.
you tell me, in world over, the preferred ARB is still valsartan.
Valsartan, yeah.
It's only India and maybe our surrounding countries where telmisartan is being used rampantly, which is not bad, I would say, as long as blood pressure is controlled and patients are happy. At least something is given which is tolerated. And the other thing is the cost factor. Now it's hardly available at 1 or 2 rupees a tablet, generic forms.
Yeah,
So,
yeah.
yeah. And Ramipril as on today is still expensive than telmisartan. So, no way in hypertension it is going to beat telmisartan. But in this
Telmisartan,
situation, yeah, in this situation, at least they should still promote this drug.
Ronak, just two suggestions from my side.
Yes,
One
sir.
is the higher extension study, 30-year data for Ramipril. I don't think ARNI will achieve that in another 20-25 years. So I think you should capitalize this and
Right.
use that.
Absolutely. That's what I'm saying. Now, with this, even people will start thinking whether to replace Ramipril with ARNI. You have such a good study now. Why don't you people start marketing on those lines and capitalize on whatever studies it is?
Right. So we've already started, sir, and a program like this,
But
that's how we are
my point is, no, my point is, if at the intermediate level, if ARNI is better, then why do we look for 30 years post? Because that is the immediate outcome. If immediate outcome is better, that's it. Because we don't know about ARNI in the long run, but in the immediate outcome, it is better. So how it will score, I don't know. We'll still prefer ARNI if it's maybe in immediate
No,
outcome. It's
we are talking of this situation of Paradise MI. We are not talking of anything else. Okay, and still I would say there are situations where I give Ramipril in a diabetic patient whose blood pressure is hardly borderline, but we prefer RAS inhibitors as a long-term preventive measure or primary prevention, if you want to call in a diabetic patient with a borderline blood pressure. Such nice drug, you get good RAS inhibition, you get good long-term cardiac and nephroprotection, and the blood pressure fall is not much, which would be difficult to get even with telmisartan, the long-term benefit. Yeah, so I still prefer this drug. Only problem is
ACE inhibitors, definitely we are well experienced with the ACE inhibitors, and we are very confident with ACE inhibitors.
correct.
That's
Right.
yeah.
So maybe I think we should end this.
Yeah, Dr. Ronak, it's up to you to do closing.
Thank you so much for this very, very insightful session. I think everybody was sitting on the edge of their seats on a Friday evening, listening to all three of you give such amazing clinical pearls. Of course, Dr. Vitisha has also given me some homework to go ahead and do, and I'll come back to you on the same as well. But thank you so much, everyone, for joining in today, and thank you so much, our expert panel, for the wonderful discussion. So,
Thank
good
you.
night, good evening.
Thank you.
Good night.
Thank
Take
you.
care. Stay
Thank
safe.
you very much, sir.
Thank you.
Thank you, sir.
भाई साहब
Thank you, sir.
Yes.
अभिषेक here.
क्या ही लंबा खींचा है, बढ़िया था लेकिन
लेकिन ठीक था. Both sides were there. Both
Is
sides
the
were
meeting
there.
ended?
ARNI side was there. A side was there.
Yogesh,
Yogesh, we have ended the session, right? Thanks.
still showing as a recording. That's fine.
अच्छा हाँ, क्या बोले थे अभिषेक जी हम?
मैं कह रहा हूँ both sides was there.
अच्छा,
So it's a good, it's a balanced approach. Good discussion. Everything was discussed.
Recording stopped.
हाँ,
Now it has.
बैलेंस सेशन था ये.
वो ना बाबा तेरा 2 minute.
No, balanced session बोला ना, balanced session है. It's not.
It should be like that. It should always be like that. नहीं तो it looks very